Hi, everyone. Thank you for joining us today. I see some folks are still trickling in, so I'll just get started with some introductions and housekeeping while folks are getting settled in. Again, thank you everyone for joining us today. Welcome to this overview of Ryan White HIV/AIDS Program Healthcare Coverage Assistance Coordination. My name is Dori Malazanov. I'm a senior manager on NASTAD's Health Systems Integration team. And I'm joined today by Amy Killalay, who is going to start off our discussion with an overview of Ryan White Insurance Assistance, what it is, how it works, and considerations for programs in making decisions about how to provide insurance assistance to clients. Then I will walk through an exciting new resource from NASTAD that's specifically focused on serving Ryan White clients with Medicare. We'll then have a few interactives. We'll also have a few interactives throughout the presentation to keep things interesting. You'll need either a smartphone or a computer browser for at least one of those activities. So make sure to have that handy as well and let you know when it's time to engage. The presentation will be recorded. It's already being recorded. We will pause for questions in the middle of the presentation, and then we'll have time for questions again at the end. So feel free to use the questions feature to submit your questions anytime as they come up to you. There's a Q&A icon on Zoom that lets you submit questions. We prefer you use that over the chat if possible. So please use the Q&A feature to submit any questions for us. We will address them throughout a couple points throughout the presentation. So with that, I will hand it off to Amy to get started.
Terrific. Thanks, Dori. And hi, everyone. So I'm Amy Killalay. I'm a consultant working with NASTAD, and for this presentation and for the resource that I'm going to be talking about, this is a HRSA HIV/AIDS Bureau resource. So next slide. So to just give you a little bit of a sense of what I'll be covering before kicking it back over to Dori. So as I referenced, there is a forthcoming resource that the HRSA HIV/AIDS Bureau has developed, and it is essentially an overview of healthcare coverage assistance programs across Ryan White Part. So it is not an ADAP or Part B specific resource. It really is meant to be a sort of primer, for across Ryan White Parts for the considerations in setting up an insurance or coverage assistance program. So what I want to do today, I will not, dramatically read what is a fairly dense resource. I'm just going to sort of stick to the high level pieces and points that are in the resource to give you a sense of what's in there and how to use it. So know that this is going to be the 10,000-foot view to sort of hopefully pique your interest in accessing and using the resource. And the elements that I've pulled out of the resource to share with you today are sort of an overview of the how insurance assistance kind of fits within the Ryan White statutory scheme, and then spending the most time on this second chunk of the different elements of an assistance program and considerations for each element. And so you see those in bullet points there. And then ending with, again, like we could have a 3-hour conversation about financing and budget considerations for insurance assistance programs, but just walking through what is included in the resource and some of the top line considerations, questions to ask as programs are considering launching or just assessing funding for insurance assistance programs. So that's the long and short of it. Let's dive into this first part. Next slide. Thank you. And one more. So, the point I want to make here, I think folks are fairly familiar and know in your hearts and minds that insurance assistance is an integral part of what Ryan White recipients and subrecipients do, as providing clients with assistance for their insurance premiums and cost sharing is not only allowable under the statute, it's an explicit and important part of the Ryan White statute. And together with the statute and with the HRSA HIV/AIDS Bureau policy clarification notices and the pertinent one, 1801, one of the pertinent ones rather, 1801 is referenced on the bottom there. There are basically there are many parameters, right? But two major parameters for insurance assistance programs. The first is that the plan or the coverage that the program, the Ryan White Insurance Assistance Program, is helping to cover has to cover at least one FDA-approved medicine in each drug class of core ARVs, and also has to cover appropriate HIV outpatient and ambulatory health services. So that's like the content, right? Like you can't buy and shouldn't use federal dollars to buy a plan that doesn't cover adequate HIV services. That's kind of baseline. With the ACA and with the benefits requirements that came with the ACA for a large swath of private insurance, we actually see this test being met by not all, but by most products out there. And then the second one, which gets a little bit trickier, is that the insurance assistance program has to be cost effective. So next slide. And I've pulled out here, and this is a screenshot from what's in the resource, but this is should be part and parcel of how Ryan White programs, how ADAPs have approached insurance assistance. This is included in the PCN 1801 mentioned and cited on this slide. But just to pull away from this, that cost effectiveness is number one. It is a broad test that looks at the cost of paying for health coverage as compared to the cost for paying full cost medications. It's like, if you think of it as a ledger, you've got healthcare coverage, premiums on the one side of the ledger, and then full cost medications on the other side of the ledger. And the other point here is that the cost effectiveness test looks a little different across the Ryan White parts. And so I've sort of divided out ADAP there and part A, B, C, D. The takeaway here, though, is that, this is a really broad test, and HRSA has not been incredibly prescriptive about how ADAPs should do these calculations. But it's an important component sort of in thinking about setting up an insurance assistance program, that this test has to be met in the aggregate. So it doesn't have to be client by client. You look at your insurance assistance program in the aggregate. But it is something to consider, as especially when we talk at the end about financing and budget considerations. So I wanted to start there. I mean, those are sort of the statutory and policy considerations. And now, next slide, Dory, I want to move to some of the more nuanced decisions, right? You've got statute and policy clarification notices from the HRSA HIV/AIDS Bureau. They give you the rules of the road, but there are many, many decision points that Ryan White insurance assistance programs have to make as they set up, as they expand their programs. So next slide. So I'm going to walk through the sections of the resource, and I'm going to pull out different decision points raised. And those are necessarily going to be covered in more detail in the resource. But just like to sort of walk into this, and we'll start with this first topic in front of us. But setting up an assistance program is it's a bit of a choose your own adventure. And the set of choices that are available and that are going to make most sense are really going to be dependent on jurisdiction level factors. So, state health department structure and capacity, available funding. That's going to be a big driver as to how you set things up. The coverage landscape in your state. Are you a Medicaid expansion state? Are you not? Among many other factors. So that what I'm going to aim to do here is kind of go through some of the different decision points and then some of the questions that that programs should be asking themselves. But no, this is not a substitute for a deep dive in the resource itself. So this first one we sort of start at the beginning in the life cycle, right, of insurance access, and that's around outreach, eligibility, and enrollment. And the coverage landscape is fairly complex. You've got all of these different types of public and private payers here. So the individual market, the marketplace and off marketplace individual ACA plans, right? That's a big, but probably not the biggest part of many programs, insurance assistance, available resources. You've got employer sponsored coverage. So, clients who are coming in with some form of coverage from their employer. Medicare and Medicaid, so huge payers for people with HIV. And then this catch all other. There are other payers and programs that don't fall within the traditional buckets, and but also have to kind of be considered. So next slide. So for this, the outreach and enrollment piece, these are some, but not all of the decision points that, that programs will ask. The first sort of threshold, will the program or should the program use in-house staff to do eligibility enrollment, or should that happen outside of the program? Should that happen with a broker, for instance? Should that happen with community-based organization contacts? Should the program structure their enrollment staff to be full-time, working year-round, or should the program use contractors or seasonal staff that are available at certain high enrollment volumes of the year? Some jurisdictions and programs sort of structured to have peak enrollment staff during open enrollment, and then sort of not rely on that peak enrollment staff during other times of the year. How should the program ensure that folks who are doing outreach and enrollment work with Ryan White clients are trained and ready and have the expertise needed? Is that an outside certification program, or is that an internal training, or is that some combination of both? And then, this piece, how and should programs limit the types of plans in which clients can enroll, and how does that get communicated to clients and to enrollment staff in the jurisdiction? So we're going to pause throughout and just kind of get a little bit of a pulse check out there for how some of you out there have answered these very questions. So I'm going to pause, and Dory's going to put up a poll for us. So on this poll, we just wanted to take one of these questions. How does your program train its enrollment staff? And so you've got sort of three options here. Staff receive training from external certification programs. So for instance, a certified application counselor training. Staff receive training that has been developed internally by the health department or Ryan White program. And then the third option, both. So we'll give folks a second. Okay, and then Dory, I don't know if there's a critical mass, but maybe we can see what people said. Okay, well, interesting. So we've got sort of a mix. The least amount in the external certification programs, and the most amount in training that has been developed internally, and then a fair amount with both. Which makes sense. I mean, that internal training, it's it certainly is more labor intensive, but ADAP is tricky, and the intersection between ADAP and insurance coverage is tricky. So that makes sense that many of you out there have chosen to have sort of homegrown training that is able to sort of bridge those nuances. Okay, so next slide. All right, so I'm going to walk through in rather short order some of the different pieces of an insurance program, and these next several ones are going to be around the nuts and bolts of sort of what costs are covered, right? So premiums, that's one of the biggest costs, the monthly cost of insurance that is paid directly to the plan. So next slide. So, around premiums, the resource walks us through different questions that programs have at the outset, similar to some of the outreach and enrollment questions. Should the program process premium payments in-house? So the health department or the Ryan White recipient is cutting checks and sending them out to the issuer, or should the program contract with a vendor like an insurance benefit manager to make payments? Should the program make individual payments to a plan for each client? So each client gets their own check that is mailed to the plan, or should, in the name of efficiency, should a program make bulk payments for multiple clients? You can kind of weigh the efficiencies versus the risk of something happening is going to jeopardize more payments in a bulk payment situation. Should the program make monthly premium payments on behalf of clients, or should they negotiate with a payer to make payments at longer intervals? So for instance, quarterly. Again, cost benefit there. You've got efficiencies, but then you also have some risk of amounts changing and the program not keeping up with that. And then this last one, a little bit of an outlier, but a decision nonetheless. Should the program purchase a standalone dental plan, which it can do, and in addition to individual plans? Is that part of sort of the full gamut of access and to services that the program can and wants to make available to folks? All right, so I'll pause. I think we've got another poll question that Dory will put up. All right, so this one is around premium payments. How does your program process premium payments for its insured clients? So premium payments are processed in-house, so by the health department. Premium payments are processed by an outside vendor. So that could be a community-based organization, or that could be like an insurance benefits manager vendor. And then 3, it depends on the type of coverage the client has. Okay, so we'll give folks a second to vote. Okay, let's see what people said. Thanks, Dory.
Amy, I don't think we hear you if you're speaking.
Oh, I was speaking. Can you hear me now?
Yes, we didn't hear your summary of the poll results.
Oh, sorry, I can't see the summary. Do you have that up on the screen? There we go. Thank you.
My apologies.
No, you're fine. I was legitimately not speaking, so that's good. Everything is good. Okay, so let's see how people are doing this. Again, like it just varies. Yeah, so about almost 40% of the premium payments are processed in-house. We tend to see that with bigger programs that have higher volume. And then premium payments are processed by an outside vendor. And actually, I don't know why I said that. The volume is probably more indicative of you might process in-house if you don't have a bigger volume. Using an outside vendor works in a variety of settings for a variety of reasons. And then some actually say that this varies depending on coverage type. Okay, great. Thank you, Dory. All right, next slide. So we're going to go through the 2 cost sharing examples here. So first, prescription drug cost sharing. So here we're talking about the coinsurance or the copayment for the drug, the medication. And I'll say, this often the prescription drug cost sharing and the medical cost sharing, the mechanism for paying a copayment and coinsurance is going to be the same as the mechanism for paying the deductible. In some states, in some jurisdictions, this may be a little bit different. In most, though, it is the same. The deductible is just the amount you're paying sort of for the full cost, the full negotiated cost of the service before the plan kicks in. But functionally, it works very similar, if not identically, to how the cost sharing is paid by a Ryan White program. Okay, so next slide. So we've got some questions here. Should the program process prescription drug payments in-house or contract with a vendor? Here, instead of an insurance benefits manager, that vendor is often a pharmacy benefits manager. Should the program use a limited pharmacy network or set up open access? This is a question that all ADAPs have had to answer, and other Ryan White insurance assistance programs are having to answer. What does the pharmacy network look like, and what are sort of the costs and gains, the strengths and weaknesses of limited versus open or more open? And then finally, should the Ryan White insurance assistance formulary mirror the ADAP full pay formulary? We know this question is answered differently depending on the jurisdiction, and it's also a tough one. Okay, let's go to another poll. Thank you, Dory. Okay, does your Ryan White insurance assistance formulary mirror the ADAP formulary? So single choice, yes or no. Okay, let's see what they said, Dory. Okay, so majority said yes, the Ryan White insurance assistance formulary mirrors the ADAP full pay formulary, so those are the same. And then not an insignificant amount said no. Those 2 formularies are different. I think we see that for different reasons. And so that's another decision point and another point that's discussed in the resource. Okay, next slide. And then the last kind of piece of the puzzle that I want to talk about in terms of these service provisions are medical cost sharing. So again, a co-payment or co-insurance for unlike the prescription, for a medical visit or service that a Ryan White client receives. And again, we're functionally often including a deductible amount that somebody would pay before the plan starts paying. So let's walk through the next slide, the different programmatic considerations here. And these are very similar to the considerations that we just went through for prescriptions. And the threshold question is around capacity and what can a program handle or want to handle in-house versus contracting with a vendor to make payments. We see, programs that are making medical cost sharing payments for clients. Many use a vendor to help, sort of create a network and to manage invoices. And then, some also go different routes and manage those payments themselves. Should the program use a limited network of providers from whom it will accept cost sharing invoices, similar to the pharmacy network question? And really, this is about sort of administrative burden and complexity and being able to have and make relationships with either a small or a large set of providers that a client might see and from whom the client might generate a cost sharing invoice. So that is a sort of threshold question of what can the program do and what is the administrative cost of having a broader network as opposed to a limited network. And then finally, the programs are not unlimited, and some programs put pretty heavy guardrails over the types of services for which the program will pay medical cost sharing. Unlike, prescription ARVs, like that's going to match the formulary, but with medical cost sharing, some people have guardrails and say they'll pay any services for which the Ryan White program would pay. And some, sort of limit those services for which it will pay medical cost sharing, mostly for budget reasons. So next slide, let's walk through some poll questions. So I'm sorry, I lied, Dory. Poll questions, not next. I said two different things. All right, last poll question. How does your program process medical cost sharing? So we've got option 1, medical cost sharing payments are processed in-house. And then option 2, medical cost sharing payments are processed by a vendor, like a medical benefits manager, for instance. And then 3, it depends on the type of coverage the client has. Let's give folks a second to answer that. Okay, Dory, let's see what folks said. All right, so a mix, but the majority of folks in that middle bucket, medical cost sharing payments are processed by an outside vendor. So that's good to know. And if you're a program out there thinking, well, I'm interested in expanding to medical cost sharing, know that 26 of your colleagues on this call are using an outside vendor, and we can certainly facilitate conversations about what that has looked like and what RFPs have looked like and what contract provisions look like in that seems to be a growing trend that's far greater than the number who is doing cost sharing payments in-house. And then some who, again, like the other question, it depends on the type of coverage. Awesome. Okay, well, that takes us through our polls. Next slide. I'm going to go quickly through this next session and hand it over to Dory, but I want to say at the outset, though, this is like major caveat disclaimer. Rebate revenue and rebate sort of projections, that's an area that's tricky and complex. And so I am emphatically and intentionally not getting into the weeds on that here. This is a topic that NASTAD provides TA on regularly. And so what I want to do here is just point out where to find this information in the resources, sort of a reference point for the how to think about these conversations and the different models that can fund insurance programs. And I will also say, like, off the bat, I think there are 2 guiding principles that come up for insurance assistance funding and really like thinking through the funding and budget implications for those. One is navigating different funding streams to ensure that as many coverage assistance services as possible can be covered. And by that, I mean basically the services that are listed out on the left-hand side of this chart. So the different types of assistance that folks need to to have their coverage remain affordable for them. And this bucket of navigating funding streams includes understanding the limits of what, for instance, ADAP versus Part B and other Ryan White parts can pay for. And like, what's the sweet spot? How do you put together cross-part funding to get to what is hopefully a bigger whole for the client? So understanding the limitations of one pot and the flexibilities of another, and using them sort of in tandem to maximize, essentially what you're able to fund. And then the second piece is really looking at funding strategically so that the insurance program can generate revenue to sustain itself. So unlike other service provision, that you're doing through the Ryan White funding, insurance assistance programs can actually generate revenue and not only sustain, but grow programs. So those are the two big pieces. And so I would just say, like, that is the frame for how this is dealt with in the resource, and how I think it makes sense to start thinking about insurance assistance program financing and budgeting. And basically, there are two models that, there are more models that are walked through in the resource, but I include two here. This first one is on rebate generation and rebates generated off of prescription cost sharing assistance in particular. And so here, that you've got the centering on ADAP, because we're talking about prescription drug cost sharing assistance, and really looking at how ADAPs can position themselves to use the rebates generated off that prescription cost sharing to fund the program. Just a quick plug too, which is referenced in the resource, that NASTAD has a cost effectiveness tool that really helps ADAPs put a finer dollar amount on this, of depending on what type of plan design you have, your clients are enrolling in, what type of revenue can be generated. So next slide. And, this is just a small point. I wanted to just do one comparator for the rebate model, and that's program income. We know that coverage assistance programs are being operated across all parts, not just ADAP, and many of those other parts and Ryan White recipients and subrecipients are sustaining themselves through program income. So, this is a financing model that just applies across a broader swath of programs, ADAPs and other Ryan White recipients and subrecipients that are 340B eligible entities. So the funding's a bit broader. We're talking about ADAP categories and also the HPSCA service categories across other Ryan White parts. And the revenue possibility there on the right is it's not partial pay rebates like the last model we just discussed, which is just an ADAP thing. It's the ability to basically pay low and charge high. So the program can purchase the drug at 340B or sub 340B discounted price, and then get reimbursed by the insurer at a much higher usual and customary price, and then invest that difference back into the program. So next slide. And I'm going to just end with, I don't mean to end with a controversial topic, but I sort of have here, is that the last part that the resource kind of walks through, and that I think it sort of comes up organically when we talk about those two models that I just went through, the rebate model and the program income model, especially when you're talking about program income models, the possibility for competition and misalignment across Ryan White parts, it is great, and we know that that's happening out there. And so we do see some tension, and I'm not going to go through this example in detail. I sort of laid this out just to kind of, like, in very clear terms, walk through where and how this tension could occur when you've got an ADAP program that is providing premium assistance, and then you've got in this case, a Ryan White Part C clinic that is providing HIV care, and both entities could be eligible for the 340B discount, but only one can claim it. The takeaway here, like, I'm not going to get into the weeds on this, but the takeaway is that when you're setting up an insurance assistance program, and when you're thinking about the financing and budgeting implications of an insurance assistance program, you got to look at the whole ecosystem of the Ryan White universe, including what other recipients and subrecipients are doing in the insurance assistance space and are doing in the 340B space, because that could really impact your budget projections. And I know that folks on this call are no stranger to this conversation, but I don't know that in in this this tumultuous time we live in, we can have a conversation about insurance assistance without talking about 340B implications and 340B cross-part collaboration and alignment. So that's basically the summary and the plug for the resource. With that, I think we're going to pause and see what questions have come up before we turn to Dory. All right.
Sure, we have a few questions. In the interest of time, I think I'm going to skip over some of the submissions here. There are more like comments, and I'll just focus on the questions. So, although we do have a reminder here that ADAPs cannot purchase standalone dental. Okay, Amy, I have a question for you. Will the resource, or will NASTAD in general be addressing paying premiums for Medicare supplemental policies, despite what is in the NASTAD resource? HRSA has yet to let us know definitively if it's allowable.
Yes, I'll probably answer that question with probably not a very not a very satisfying answer, which is to say that the HRSA has put together this resource, and I don't believe that this resource is in conflict or adds any guidance on that very issue. So I will say I think we're just in the same we are in the same posture on that issue, where it's not addressed explicitly.
Thanks. And we have one more question. Have states that use an outside vendor for medical copays run into problems with clinical sites being unwilling to accept payment from a third party? Sorry for the honking.
You're fine. So states that use an outside vendor for, so that's interesting, Annette. Not that I have heard, and it shouldn't matter. I could see that, like, potentially that it could be a flag. I have not heard that come up, but if it is a qualified health plan, it would fall under that third party payment. Even a medical, it's any payment made by a Ryan White insurance assistance program has to be accepted by the issuer. It shouldn't matter that a vendor is in between it. And I have not heard that come up. I know, that Dory and I heard from one jurisdiction that there was a problem with an issuer accepting a payment made from a Ryan White provider, and that was not counting that Ryan White provider as an entity that was covered under the third party payment rule. And I think that the jurisdiction was working to sort of educate on that, but I haven't heard vendors running into trouble. And if others have, they should certainly weigh in on the chat.
Thank you. We actually have someone from Oklahoma submitted a comment in response to that in the questions here, so I'll read it aloud. That Oklahoma has had medical providers not wanting to participate.
Oh, so not wanting to invoice the program for cost sharing. Okay, I'm guessing that's what it was actually, but.
Let's see. Okay. We also have another comment here in Colorado. We've run into that issue, but we have a coordinator that does outreach to providers. We also have the ability to process manual claims. Also, by the way, folks, feel free to add, comments or things to add to questions through the chat. The Q&A feature is helpful for us to manage questions that, we need to read aloud to presenters. But if you have just, additional thoughts that you want to share with the group about the questions being asked, feel free to use the chat function for that. It'll ensure kind of, everyone's able to see it in a timely manner. But loving the engagement and enthusiasm, everyone. Okay. So let me just make sure we don't have any other questions here. Will you,
you should address that if Jeff's in your Medicare section, Dory. That's all you.
Jeff, I will pause on that until we get to the next section will be about Medicare, but that is a good question. Okay, so I think now I'll move on and continue with the next portion of the presentation. However, if more questions do come up for Amy, feel free to drop them in here and we will address them later. Okay, so moving along. So now I'm going to talk about a new NASTAD resource focused on Ryan White Part B and ADAP coordination with Medicare. I know we have some Part A folks on the line as well. This particular resource was designed for Part B and ADAP. However, we, from a sort of, administrative standpoint, but we think that most of what's included here will be relevant to other Ryan White parts. So we hope that our Part A friends will stick with us and for the next portion of the presentation, as well as for further Q&A. So today I'm going to talk about another resource that is currently available on the internet that from NASTAD that Amy and I have worked closely on for some time now, and we're finally excited to show it to the world. So I'm going to talk about how it's structured and how it can be, you can use it to support your work with Medicare clients. So I'll kind of go through the different components of this resource, the importance of the Medicare program for Ryan White clients, eligibility and benefits in Medicare, enrollment considerations for Part B and ADAP clients and programs, Medicare costs, and then some partnerships and resources that Ryan White programs can take advantage of to support them in this work. So my goal today is not to provide a lesson on the inner workings of the Medicare program, which would be impossible to do in just one short webinar, but rather walk through the topics covered by NASTAD's resource and maybe add a little bit of some educational material as well. So at the bottom of the slide here, I've dropped a link to the resource itself. I'm also going to drop it into the chat right now. And additionally, I'll be following up with everyone over email in the coming days with some additional information. So I'll include that there as well. So you will not miss it. So first, the growing importance of Medicare for Ryan White clients and for people living with HIV in general. But Medicare is an incredibly important piece of the HIV care landscape in the US. It's the single largest source of federal financing for HIV care and treatment. In 2016, 50% of federal financing for HIV care came from Medicare, and 25% of people with HIV in care were insured through Medicare. So half of federal financing for care came from Medicare, in addition to 25% of people with HIV who were in care receiving their coverage through Medicare. Historically, the majority of people with HIV in Medicare have been under age 65 and qualified based on disability. However, that share has been declining over time as Ryan White clients age. More are also entering the Medicare program at age 65 and older. I unfortunately don't have more recent data points on this breakdown. We believe we have a good authority that updated data should be available soon. However, data on age demographics of Ryan White clients in general is much more current, so we can take a look at that to kind of get a sense of the trends. So the demographics of Ryan White clients indicate that the proportion of clients eligible for Medicare based on age will only continue to grow over time. So in 2008, just 2% of ADAP clients served were age 65 and older, and that has grown steadily over time to 11% in 2021, which is just 13 years later. And when you look at the Ryan White program overall, more than half of clients are over age 50. So Medicare is already and is becoming more and more important for the Ryan White program and its clients over time as the population of people with HIV ages. Of course, not every Ryan White client is over age 65 is eligible for Medicare. There are other requirements for eligibility requirements. There are also some clients who, for whom it might not be a best coverage option, even if they are available. But this data still helps paint a picture, I think, of the importance of Medicare for the Ryan White clients and especially older clients, because it shows how steadily the age 65 plus Ryan White client population is growing. Now we're going to do another poll. We'll launch here. Folks should be able to see it. The question here is the proportion of our program's Medicare clients that are over age 65 has either increased over time, decreased over time, or remained steady. All right, we're about half participation. Oh, things are coming in pretty quickly still. So, all right, we're just over half. So I'm going to end it now so we can keep things moving. it looks like the vast majority of respondents here say that the proportion of Medicare clients in their programs over age 65 is increasing over time. So, that does pan out with what we're expecting in coming years, and it tracks with what folks are already seeing and have been seeing for some time now. So, great, thank you. Oops, stop sharing. Okay. Moving on. So now let's take a look at NASTAD's resource and how it might be of use to your programs. So first, eligibility and benefits, Medicare eligibility and benefits. Of course, NASTAD's resource goes over the different ways that folks become eligible for Medicare. We try to include some nuanced rules and exceptions that you might come across as you're working with clients, since of course, when it comes to Medicare, nothing is simple. And of course, it explains the different Medicare parts and the services that they cover. So now for a little bit of additional content. One of the major wrinkles, we can call it, in Medicare eligibility rules comes up when working with non-citizen clients. Our resource does not specifically highlight this group, so I wanted to raise some considerations here today, and then I'll pose a question to the group, to this group here, to gauge how these issues are coming up for your clients. So I mentioned earlier that Medicare is sometimes not the best option for a client, even if they're eligible for it, and non-citizens are a prime example of how that could happen. So Medicare Part A, which covers hospital care, has no monthly premium if a client has worked and paid federal income taxes in the US for a total of 40 quarters in their lifetime. That's about 10 years cumulative of working and paying taxes in the United States in order to qualify for free Part A. However, you only, as non-citizen, only has to live in the US for 5 years to be eligible for Medicare, among other criteria, of course. So they're lawfully present non-citizens, especially those who immigrated to the US later in life, could be eligible for Medicare, but may not have worked here for 10 years. Some may never accumulate 10 years of work or any amount of work in the US at all. Someone who's eligible for Medicare but lacks 10 years of work history could pay as much as $500 per month for Medicare Part A hospital coverage, in addition to premiums for other Medicare parts, Part B and Part D, and out-of-pocket costs. If they're eligible for Medicaid, that could help reduce or eliminate these costs, but of course, not everyone is going to be eligible for Medicaid. By contrast, non-citizen clients who have worked and paid taxes in the US for 10 years pay no premium for Medicare Part A. So clients with fewer than 10 years of work history also have to meet some additional requirements to be eligible for Medicare at all. They have to have a green card. They must have resided in the US for at least 5 continuous years before applying for Medicare, and they must have resided. Lawfully present non-citizens who do have enough work history don't have that 5-year length of residency requirement, and don't necessarily have to have a green card. There are some other qualifying statuses, although in practice, clients that with that much work history are generally going to be either green card holders or TPS, temporary protected status. Just to show here that in addition to higher costs, non-citizens over age 65 face additional barriers even to eligibility in the first place, and then even if they are eligible, their costs could be much, much higher. So I myself have non-citizen relatives, so I'm older non-citizen relatives, and I'm personally aware of how confusing all of this can be. So please do not hesitate to reach out to us for technical assistance about this at any time. We understand that this is of growing concern to programs as more immigrants are growing older as well, and engaging with Ryan White services and insurance, and we are here to support you. So given these barriers to affordable coverage for many older non-citizen clients, here are some questions that can help guide those coverage decisions, and all of these considerations are topics that are addressed in our resource, even if not specifically tailored to non-citizens. So it's an example here of how our resource can help with some of the decision-making that comes along with navigating Medicare with clients. Even if the client does not themselves have work history for free Part A, perhaps their spouse does, as long as they've been married for at least a year, the client might be eligible based on their spouse's work history. Of course, if the client is eligible for Medicaid, that will assist with some or all of their Medicare premiums, possibly their out-of-pocket cost as well. If the client has employer coverage, either through their own work or through their spouse, delaying Medicare enrollment might be a viable option. Our resource talks about considerations when deciding whether to delay Medicare coverage in this kind of situation. Clients who must pay a premium for Part A are eligible for marketplace coverage financial assistance. clients with free Part A are not. But we do talk in the resource about that transitioning between Marketplace and Medicare and making decisions between the two types of coverage when both are available. Of course, though, there are late enrollment penalties if the client delays Medicare in favor of Marketplace coverage. So, our resource can help you weigh, the cost that those late enrollment penalties against the benefits of delaying in that client situation. Okay, and the wonky part of the presentation is over. I have a couple more topics to cover after we do a short interactive activity, and then we will go back for a few more questions for Q&A. So bear with me technologically, please. Hopefully folks can see this question on my screen. Amy, maybe you can let me know if you see it.
Yep, I can see it.
Amazing, great. So earlier I asked folks to keep a smartphone or a computer ready. So nearby, whether you're on your phone or your computer, there's an address there at the top of the screen that I can't see because of my presentation panel, but I know that it's there with a URL and a code you can type in, and then you should be able to type in a response to the question if you'd like. Hopefully folks are able to use it. Right, maybe not. Folks paying attention? Oh, here we go. So the question here was, sorry, what challenges has your program faced with older immigrants accessing Medicare? I should have said it out loud. A little flustered. It's my first time using this feature, so please bear with me. So as you see, you can type in as many responses as you'd like. They'll post anonymously on the screen. You can go ahead and submit as many as you like, and they'll continue to populate here. All right. Lack of work history. Yep, that's to be expected. Language barriers, of course. Lack of trust. Yeah, that is definitely something that we experience with Ryan White clients, and for example, around public charge policy and other immigrant unfriendly policies. Language barriers, inability to access support in your language. Yeah, I've experienced that even personally as well with my family. Yeah, resistance to change. Definitely experienced that one. No, we have some responses coming in here. I'll give folks another minute to submit some responses, and then I'll just go quickly over a couple other things before we continue. All right. Confusing. Yeah, just afraid of all of the above. Yeah, SSA offices are still inaccessible for in-person appointments since the pandemic. That has definitely been a barrier I've seen. All right, well, I'm gonna move on in the interest of time, like 10 seconds. So get in your last responses now and we'll move on. Well, these are some great responses. Hopefully folks, are seeing things up here that are resonating with your experiences, even if you didn't participate. And of course, we are interested in hearing from folks anytime about any challenges that you're experiencing with Medicare in general, with immigrant clients in particular, and any way that we can support with these, update our resources to account for these challenges, and account for them in our presentations like this one, et cetera. So there'll be contact information later on in the presentation, and I would love to hear from folks about these things. But for now, I will have to move on from this. So you should be able to see my slides again now. Okay, so moving on, we'll talk about enrollment considerations. This section of the resource covers the different types of Medicare enrollment periods, not just when they occur, but also what they allow you to do. Some allow for only new enrollments, others allow changes to existing coverage. Of course, timing is important to keep in mind when planning a client's transition to Medicare. So the resource talks about how to help clients decide whether and when to transition to Medicare from other types of coverage. Helping clients choose between original Medicare and Medicare Advantage. There are several factors to consider here, such as cost and provider networks, and the resource walks through financial assistance that's available through the Medicaid program. Eligibility criteria for different types of Medicaid programs that are available to Medicare enrollees, and the types of assistance that these programs provide. There are some exciting policy changes in this area taking effect this year. I'm going to quickly talk about them now in the interest of time. First, there's in the past, clients that could wait anywhere from 2 to 6 months for their Medicare coverage to start, depending on when they enrolled. That coverage gap has been eliminated. Coverage now begins the month after enrollment. However, enrollment is still limited to specific enrollment periods, so coverage gaps and late enrollment penalties could still occur if clients miss an enrollment period and need to wait for the next one. However, when they do finally have a chance to enroll, with or without a penalty, the gap of the amount of time they have to wait for their coverage to start will be is shortened, and coverage will start the next month. There are some new special enrollment periods as well. As you all probably heard this term before in other, private insurance uses this language as well. These are event circumstances that allow folks to enroll in coverage outside of designated enrollment periods. In Medicare, there has historically been a special enrollment period for folks who don't enroll in Medicare when they first become eligible, because they still have employer coverage when they turn 65. So when that coverage ends, they can use a special enrollment period to enroll in Medicare without any penalties. That was the main way, if not the only way, that folks were really able to, access Medicare without penalties if they missed their initial enrollment opportunity. Now, there will be a few additional special enrollment periods, and one really important one is that clients who delay Medicare will be able to, because they have Medicaid, can enroll in Medicare when their Medicaid ends, so without penalties. This is going to be especially important when the Medicaid protections that are in place during the COVID public health emergency start to unwind in the coming months. Clients are going to start losing their Medicaid, but clients who turned 65 since the pandemic started and stayed on Medicaid will be able to have Medicare that starts right after their Medicaid ends without a gap. Of course, we hope clients will enroll in Medicare as soon as they're eligible, but we also know that doesn't always happen. So, our resource will help you figure out how to help clients in this situation. When is their next chance to enroll? Do they have other coverage to fall back on in the meantime? Is there a way for them to have a special enrollment period? There are also special enrollment periods for other Medicare parts that are more expansive. And finally, premiums and cost sharing. Premiums and cost sharing for different Medicare parts are discussed in the resource. We'll be updating them with 2023 figures imminently. We talk about prescription coverage, drug coverage under Medicare. It can be somewhat complex, so we try to break it down with some good visuals. And there have been some important policy changes in this space as well, taking effect next year and beyond. So we'll be keeping the resource updated as those changes take effect. And finally, we included a list of resources, including some focused on Ryan White programs that might be helpful to your programs as you navigate Medicare coverage for clients. So sorry to kind of cut it short there a little bit at the end, but I just wanted to make sure that we had enough time for questions. So that will be the end of my presentation for now. And here's my contact information if anyone has questions, and let's see if we have any questions.
Great, thanks, Dory. So yes, let's start with the one that we delayed from Jeff Morris. Relating to the premiums and cost sharing piece that you just mentioned, does the resource address ADAPs assisting with Medicare Part B plans? And the understanding here is that that's unallowable right now.
It is not so much unallowable as it is not mechanically, not technically feasible. So it's Ryan White funds can be used to cover Part B premiums. However, since clients generally receive clients' Part B premiums are generally deducted from their Social Security retirement benefits automatically, there is no mechanism for making those payments. This is an important priority, for I would, at least in my opinion, at least for me, and I would say for the HIV community, to like address this issue, and we're working on it. But as of right now, you know, we have not been able to identify a way to have these payments be covered. However, a client who, such as an older immigrant who is not eligible for Social Security retirement benefits, would be paying their Part B premiums themselves, and ostensibly in that case, Ryan White funds could be used to pay for that.
Awesome. Thanks, Dory. And let's see, and I will just note that there's been a lot of chatter around the Medicare supplemental plan payments, and what has been described as confusing HRSA guidance on this. So I would we'll sort of punt that question for a later time, but recognize there is confusion out there, and I think that's a conversation to be had with HRSA. And then for you, Dory, are there additional information to prepare for the Medicaid unwinding and preparing clients? So if there's anything there that you want to plug.
Yes. So this is something that I've been working with, especially with our Part B ADAPs for 2 years now, helping folks prepare for this. So this is something that we have been talking about a lot, and we continue to work with programs through one-on-one technical assistance, and through, you know, larger disseminated resources like webinars, et cetera. So I think, I'm not sure if the person asked this question is someone who would have received information about some of the webinars that I've given on this, but I will note your name, and I can send along some resources that NASTAD has already developed and webinars that we've already given on this, as well as information about you know, other resources or upcoming presentations from NASTAD or others. In fact, I will just share that. I can just share that with everybody when I circulate the slides and recording from this. So it's a big question to answer on the phone right now. So I think to quickly kind of answer it, preparing clients right now, I would say the most important top line things are make sure everybody who has Medicaid contacts Medicaid, gives them their most current up-to-date contact information. Medicaid is going to start sending people things in the mail. In some states, it could start in the next few weeks even, and you want to make sure that all your clients get those documents. You don't want clients to get disenrolled from Medicaid simply because Medicaid didn't know where to send a letter to them. So updating contact information is the first thing that should be done for every client as soon as possible. And then beyond that, I think, you know, being aware of the process that's happening in your state and the timeline in your state, and making sure that clients know that Ryan White is there as a resource when they start receiving letters from Medicaid in the mail. And that is a very, very brief, like crude overview of that. And I will provide some more information about how to prepare for this when I circulate the slides and recording. Okay. I think we are at 3 o'clock now, so folks are going to start, you know, to trickle out. I think we actually did manage to address almost all the questions. If we missed your question or you didn't have a chance to submit it, my email address is on the screen. Please feel free to reach out with any questions, technical assistance requests, just feedback on the presentation or your experiences working with clients that you think we should know about. I want to hear from you on everything. So here's my email address, and please don't be a stranger. Okay, thank you everyone for joining us today, and I think we'll close out now. And thank you, of course, to Amy for joining us.
Thanks everyone. Bye.